joining today's virtual education program with Cancer Support Community Los Angeles. I'm Larissa Montalvo, and I am the program manager here at CSCLA. I welcome you to this week's webinar titled Personalized Treatment for Breast Cancer. Breast cancer treatment has come a really long way and is no longer a one-size-fits-all model. Therefore, we'll be joined today by Dr. Parvin Peddi to review different types of breast cancer and to explore the importance of personalizing care for each patient based on their cancer type. But before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their family members, all at no cost. Our programs include support groups, healthy lifestyle activities, educational programs such as this one, and social activities. If you'd like to learn more about our services or watch our past webinars, please visit our website at www.cancersupportla.org. Without further ado, I would like to welcome today's speaker. Dr. Parvin Peddi is the Director of Breast Medical Oncology at the Margie Petersen Breast Center at Providence St. John's Cancer Institute. After nearly a decade at UCLA, where she was a member of the Medical Oncology faculty and lead medical oncologist at the Revlon UCLA Breast Cancer Clinic, Dr. Peddi joined the Margie Petersen Breast Center. She specializes in the treatment of patients with breast cancer and is involved in designing, implementing, and leading clinical trials to test new targeted therapies. She is board certified in internal medicine and medical oncology. Welcome, Dr. Peddi. We're so excited to be hosting you for the second year in a row in honor of Breast Cancer Awareness Month. Thank you for joining us.
Hi. Well, thank you.
The floor is all yours.
Thank you so much. Very pleased to be here, and thank you guys for coming. Let me share my screen.
Okay, so I'm going to be giving a talk on breast cancer in general. Some of it would be more focused on people who want to learn about breast cancer, about diagnosis and screening, but as we go along, it will be more and more about treatment options and getting more in depth in terms of what do we do for a patient who does get diagnosed with breast cancer. So outline of my talk, and we'll start with screening. What are the recommendations, and what are the modalities? What does one see when there is a breast cancer at screening? Then what are the steps to be done at the time of diagnosis if a mass is seen for a patient with breast cancer? And then going over staging. What does that mean? What does it mean to have different stages of breast cancer? And what are the different types of breast cancer? Because that would really get into what are the treatments, because the treatments, as we talked about in the introduction, is really individualized. No longer do we have the same treatment for all types of breast cancer. So we'll go over different types of breast cancers and their treatments, whether they're localized or metastatic, so-called stage 4, and then what are the main paradigms of treatment, and hopefully leave plenty of time for question and answers. So who needs screen? There are different guidelines by different groups that are out in terms of who and when do we start screening. The current recommendation from the American Cancer Society, which most hospitals and oncologists follow, is that all women after age 40 start getting screening mammograms once a year. And in terms of what is seen when someone does do a mammogram, this is a mammogram of, like normal breasts, and they don't have any suspicious masses. And also, it's good, FYI, to do a 3D mammogram. When you go for your mammograms, it does pick up things more than a regular 2D mammogram. So this is what it would look like. Now, what would it look like if something is so-called abnormal? One thing that can be seen are calcifications. It's pretty common for calcium deposits to be in the breast, and they don't always mean something bad. Some calcifications are completely benign. For example, the the one at the bottom right-hand side. These are kind of scattered calcifications in no specific pattern, and these are most likely benign and nothing to worry about, and they don't make that person have breast cancer, as opposed to these other calcifications that kind of cluster together in one area and they're not uniformly all over the breast. And these are the ones that we get more suspicious about. Sometimes they're associated with different breast cancer stages, DCIS, like a precancerous lesion, as well as actual cancer. So depending on the degree of suspicion by the by the radiologist, sometimes these are followed with a 6-month follow-up or just gone straight for biopsy and workup. So that's if you see calcifications. On mammogram, you can also see mass sometimes as well. And this is what that would look like. In this particular mammogram, you see clearly this is sticking out. It's different from the other glandular formations of the breast. And this is a mass in this particular patient that turned out to be breast cancer. When something shows up on mammogram, whether it's calcifications or whether it is a mass, usually the next step is also an ultrasound to better visualize it. And then you go ahead with a biopsy. If you could see it on ultrasound, you do an ultrasound guided biopsy. So the radiologist is looking with the ultrasound as they do the biopsy so they know exactly where to go. Or if sometimes this is like more calcifications and it's not a mass per se, you may not be able to see it on ultrasound, then you do what's called a stereotactic biopsy, or just means by mammogram guidance. And the radiologist is basically looking at the mammogram live as they're doing the biopsy. Ultrasound-guided biopsies are a little bit easier for the patient. So usually that's why we try to go with an ultrasound-guided, but if they're, you can't see by ultrasound, then you go ahead with a mammogram-guided biopsy. And then you have your diagnosis. And this is what an ultrasound would look like of a mass. This kind of round, sometimes not super smooth as this one is, sometimes more spiculated, but definitely this darker lesion that basically is called hypoechoic, meaning like it doesn't let light through and is dark, and that's what the radiologist looks for in order to do a biopsy. And sometimes you also need an MRI. So once someone has had mammogram, ultrasound, they were found to have, actual breast cancer. Sometimes we add a breast MRI in addition to this because if someone has dense breast, they're younger, those people may know that mammogram can actually underestimate things or things can hide there. So in order to know exactly what you're dealing with, we also do an MRI for better understanding of the size and for surgical planning. And a lot of times we also do MRIs for people who have a lobular cancer, and I'll get back to that in a little bit of what lobular cancer actually means. But those cancers are more likely to be underestimated on mammogram, so more important to do an MRI for them as well. And this is what an MRI would look like. So this is the mass for this particular patient. And we can see, we just see the blood vessels otherwise, and not much else. This person has this large mass and some satellite so-called lesions in the same breast. An MRI automatically looks at both breasts as one is going through the scanner. And so one slide on genetic testing for a person who is newly diagnosed with breast cancer, to keep in mind who needs to be genetically tested. A minority of breast cancers are genetic. Majority are not, only about 5 to 10%. You can actually find the gene. Most common genes that you hear about are BRCA genes, BRCA1 and 2, but there are several other genes, including this one called PALB2, that are also involved in increasing breast cancer risk. So it would be important to know both for that person as well as for their family members. Now, who should have genetic testing done? Typically, anybody who's young, and by young, usually anybody less than 50, we would say should get genetic testing because they're more common, will have a genetic predisposition. Anyone who has breast cancer on both sides, a male breast cancer patient, anyone with first degree relatives that were young with either breast or ovarian cancer, people of Ashkenazi Jewish descent, since there is more of a prevalence of these genetic mutations, especially the BRCA genes in this ethnicity group, and anybody who has metastatic breast cancer. That's not because these people have more often the cancer, these genetic mutations, but because they actually have specific medication that can be used to treat the breast cancer, but only works in people who have the BRCA 1 and 2 mutations. So for people who have metastatic breast cancer, they should all get tested genetically as well, because it actually affects what you treat them with. So now, okay, somebody went in for their mammogram, ultrasound, MRI, they got a biopsy, they have breast cancer. What are the stages for breast cancer? So we typically think of breast cancer in two different categories, localized versus not. So localized means anything that is in the breast as well as the lymph nodes. They're all considered one location. So stage 1 to 3 is in that category. And stage 4 or metastatic is when it's gone outside of that area to any other organ. Has it gone to the liver, lung, bone, brain, anywhere else, that's called a stage 4 or metastatic breast cancer. And then in terms of the stage 1 to 3 patients, if it's super small, less than 2 centimeters, and hasn't gone to the lymph node, they're stage 1. If it's a little bit bigger or it has gone to the lymph node, it would be a stage 2. And if it's more than 5 centimeters or if it's several lymph nodes, then it will be a stage 2. So in terms of what the treatment paradigm is for these patients, stage 1, 2, 3, you try to go for a cure, but it gets harder and harder if it has spread to be able to beat all the cancer cells, but it's still very much possible. But in terms of stage 4, that is not at this moment possible in terms of cure, but maintaining the breast cancer and remission is. So what are the different types of breast cancer? The breast tissue itself is made of two different types. So the lobules and the ducts. So breast milk is made in the lobules or glands of the breast and carried through the ducts to go towards the nipple. So breast cancer can start in either of these two locations. So it can be a so-called lobular carcinoma, if it's started in the lobules, or a ductal carcinoma if it's started in the ducts. And for the most part, they're treated about the same. It's more important what kind of hormones or non-hormones they rely on for growing, rather than whether they're ductal or lobular. But there are some trends between the two cancers that help an oncologist try to figure out what to do in terms of treatment. But for the most part, we treat them about the same. But we do more MRIs for the lobular cancers because we know that mammogram can underestimate. So more important than the ductal versus lobular, like I mentioned, is more what does the cancer rely on for growing. So every breast cancer, we tested automatically for 3 kinds of receptors. The first 2 are estrogen and progesterone. They kind of go hand in hand. They're female hormones that normal breast tissue depends on for growing, and a lot of cancer cells use the same things for their growth. So we test these to see if that person's breast cancer is still, dependent on hormones, and therefore can we use an anti-estrogen method as a way of going against the cancer. And that's the majority of breast cancers that are positive for estrogen and progesterone. And then the third receptor is this thing called HER2, HER2, that is amplified or overmade in about 20% of breast cancers. So let's say this one on the left is a normal, so-called normal breast cancer cell. So it has some HER2 gene inside and some HER2 on the cell surface, but the ones that are HER2 positive have more of the gene and millions of the HER2 copy on the cell surface. And these can drive the cancer growth. These cancers, in general, are worse than other types of breast cancer in terms of how aggressive they are and how much they want to spread. But on the flip side of it, if you treat them with anti-HER2 drugs, they actually do quite well. So we'll get to that in the treatment section. So to recap about what we've said so far, the goals of therapy in general, when someone is diagnosed with breast cancer, if it's localized in the breast and or lymph node, you're trying for the cure. You're trying your best to give these patients a cure so this cancer is gone and never coming back. In people who have metastatic disease, stage 4, that has spread outside of the breast or the lymph node, right now, our science is not where we can cure most patients in this scenario, but we can prolong life and put in a remission a lot of times for a long time and improve their symptoms. So the goals are a little bit different and the treatments therefore are a little bit different between the two. So what are some types of therapy that you give before or after surgery? It could be chemo, it could be anti-estrogen treatment, or some doctors you may hear speaking to them as endocrine therapy. So one thing that I explain to my patients when I first meet them, a lot of times before surgery, is explain to them why surgery is not enough and after surgery they're not done yet. The reason for that is that when someone has invasive ductal or lobular cancer, that means that the cancer has broken out of the duct or the lobule, at least microscopically. We know that. We see that under the microscope in the biopsy. That's why it has that name, that is invasive. So these cancers, therefore, have shown that they have the potential, and maybe they have already, being able to get out of the breast and go elsewhere. So whether you find that in the lymph nodes during surgery or not, whether you can see them on any type of scan or not, these cancer cells, if they have spread, are microscopic and they can evade detection. So if you treated everyone with surgery alone, a lot of these patients, the majority of them actually, will have the cancer come back somewhere else a few years down the line because it was already out there when you got to it at the time of surgery. It had already broken out, and you needed not to just rely on surgery, but treat the patients with something that goes throughout their system to clean up if there are any cancer cells out there. So how do we clean up, so-called? Then you go with what the cancer cell type is and what are the risks that it could have gone outside and whether you need chemo, anti-estrogen, or both. So I'm going to go through each type of breast cancer and then kind of hit the high points on their treatments in general. And obviously, I can't go through everything in this talk. So hopefully, if you have any more specific questions, I can answer them at the Q&A. So first, we'll talk about the hormone receptor positive breast cancer. So these are the ones that are positive for estrogen and progesterone. So a lot of times they go through surgery first, upfront, plus or minus radiation therapy if they need it. And like I said, negative lymph node biopsy doesn't necessarily mean the cancer has not spread. And usually you give them at the very least some kind of anti-estrogen therapy, since you know these cancers are relying on estrogen for growing. So what are those treatments? It could be tamoxifen, it could be these drugs called aromatase inhibitors, or it could be a combination of aromatase inhibitors and ovarian suppression. And that kind of depends on the patient's menopausal status and what kind of side effects you think would be the least bothersome for that particular patient. In a premenopausal woman, you can use either tamoxifen or give that person monthly or every 3-month injections to suppress the ovaries, and then use these aromatase inhibitors. Because the aromatase inhibitors can't use by themselves if the women are premenopausal, because they cannot touch estrogen that is made in the ovaries. If someone is postmenopausal, then you can use the aromatase inhibitors. You can still use tamoxifen as well. And they have pros and cons to them. Aromatase inhibitors are a little bit better than tamoxifen against the breast cancer, and tamoxifen in a postmenopausal woman can increase the risk of uterine cancer. So for both of those reasons, your preference is aromatase inhibitors, but there are times that for one reason or another, you have to go with tamoxifen for a given person. Now, okay, those patients need anti-estrogen therapy. How about chemotherapy? Do some of them also need chemotherapy in addition to the anti-estrogen therapy? The answer is yes. And the way we try to figure out who those patients are, we try to see who is most at risk and who may need more help. And just anti-estrogen therapy may not cut it for them. So people who have a lot of lymph nodes positive, those patients typically, because we know they're at higher risk for the cancer wanting to come back, we usually cover them with chemotherapy as well to try to increase their odds of beating the cancer and not coming back. But also some lymph node negative patients. There's this test that some of you who have either had breast cancer or know someone who may have heard of this test called Oncotype DX, which is a test that can be sent on the tumor that basically does very sophisticated genomic analysis on the cancer and tries to risk categorize that person's particular tumor. So it's the most personalized you can get. It's very unique, that score that you get from this test to that patient themselves. And this basically tells the person that if they have a score and the cutoff is typically 25, they don't need chemotherapy if they're postmenopausal. There's more of a leeway in premenopausal women. If the score is up to 18, again, they don't need chemo. But if it gets a little bit higher, you need to have a discussion with your doctor and go over all the other attributes and try to figure out whether chemo would be right for you or not. And sometimes we add a drug to endocrine therapy. So these class of drugs, so-called CDK4/6 inhibitors, that basically stop the cells from growing, can be used in conjunction with anti-estrogen therapy for some of these patients, and was actually approved by the FDA this week. And it's a drug called abemaciclib that can improve survival in some of the high-risk patients in this category, and mostly for the stage 3 breast cancer patients. Now, that was for localized breast cancer. How about people who have metastatic breast cancer that's still hormonally driven? So for those patients, the standard right now is anti-hormonal therapy, so like let's say aromatase inhibitor, plus these drugs, again, the CDK4/6 inhibitors. They are the mainstay of treatment for these patients. And there are 3 drugs in that class: ribociclib, abemaciclib, and palbociclib, just different companies that make them, and some differences between the drugs. But you can use any of them for the most part in combination with anti-hormonal therapy, and that can double the amount of time it takes before the cancer becomes resistant to the anti-hormonal therapy in these patients who have metastatic breast cancer, and have a discussion with your oncologist to figure out which one. And then once patients' cancers have become resistant to anti-hormonal therapy, these patients with stage 4 then go through chemotherapy or a clinical trial. Then whatever works, you continue it as long as it does and continue imaging. So that was a whirlwind of hormone receptor positive breast cancers. So now we'll hit the highlights on HER2 positive breast cancers. So, like I mentioned, this is about 20% of breast cancers, and they're more aggressive compared to the hormone positive ones that we just talked about. So for that reason, and because our drugs are so good, we actually usually give chemotherapy for these patients before surgery. So number one, they need chemo, and number two, you actually do it before surgery in these patients for better survival and better outcome. And chemotherapy is typically combined with Herceptin, which is an anti-HER2 drug. And you don't need to go through all of this stuff, but it's like more meant for doctors and scientists, this diagram. But what I wanted to show you is that this is the HER2 receptor, like I showed you on that other diagram before. And it typically, if there's no Herceptin around, it binds to other HER2s and causes cell growth after it dimerizes, becomes a couple. But if there's Herceptin around, Herceptin binds to the HER2 and doesn't let it dimerize, and therefore this cell growth no longer happens. So Herceptin, which is an anti-HER2 antibody, is a mainstay of treatment for these patients, combined with chemotherapy and sometimes with other drugs, such as this drug called pertuzumab or Perjeta, which is another anti-HER2 drug. And if you do it right and you treat them with the right cocktail, these patients have wonderful outcomes. And sometimes when you go for surgery, there's no cancer left, which is what you want to get to. And so you go for surgery afterwards, and if there's no cancer left, you still continue Herceptin for about a year, just to make sure you've covered your bases. But Herceptin by itself doesn't really have any side effects. And it's just an antibody. It does require an IV treatment every 3 weeks, but no hair loss, no nausea, and basically not much in terms of side effects. And if the cancer is not all gone at the time of surgery, there's actually a better option than Herceptin, this drug called Kadcyla, that I will go through right now. So basically, what Kadcyla is Herceptin plus a chemo in one molecule. So this is what it looks like. This top part is the Herceptin, and it has a linker. And then these little things are basically a chemo drug that is powerful chemo drug that is linked to the Herceptin. Then when this whole drug, Kadcyla, is given to the patient, it goes in, chemo doesn't touch anything else until the whole molecule finds HER2 on the surface of the cancer cells. And then with the whole thing gets inside, and only when it's inside is the chemo released. So this is like the holy grail of oncology, because you have the delivery of chemo not just to anything that moves, not just to any cell that divides, but specifically to cancer cells. So this Kadcyla is so-called smart chemo and was the first smart chemo of any kind approved in any cancer when it was approved a few years ago. So if the traditional chemo plus Herceptin didn't finish the job before surgery, and you went for surgery and there was still cancer cells left, then these patients would be ideal candidates to now use this very nice new drug called Kadcyla. So, which makes it more critical to get chemo before surgery. So you have the option of using this afterwards if chemo was not enough, which you wouldn't have known if you just did it after surgery. So this is basically what I've already mentioned. Kadcyla was the first smart chemo approved in breast cancer or any other cancers, approved for use after surgery, and this approval came just a couple of years ago, and rates of breast cancer recurrence was cut in half when people use this instead of Herceptin. And just FYI, for metastatic HER2 positive breast cancer, there's another drug that is on the market called Enhertu that seems to be really good as well, and also targets chemo to HER2 positive cells. And in one trial, the response rate was 60%. These are people who've been through like 5 lines of other treatments, 5 other chemotherapy drugs. So usually you don't get a whole lot of response from whatever you try at that point, at the 6th treatment, but 60% of them had a response. So this one is also approved for metastatic breast cancer patients, and now we're trying to figure out, does it beat Cat7? Can it be used for people who don't have metastatic but early breast cancer? And then lastly, there's a new category called HER2 low. People who don't have HER2 positive breast cancer, but they have a little bit of HER2. Is this drug so good that even can help them? So those are things that are right now ongoing in clinical trials. And just a few other drugs to mention. Another one is called tucatinib. It's an oral drug. It's a pill. It can also treat brain mets. This is again for metastatic HER2 positive cells. So it's great that people don't have to go to brain surgery or radiation, and you just put them on a pill. And this pill can actually treat the breast cancer that has gone to the brain. And this was approved last year in terms of use. So that's what I'm going to talk about for HER2 positive breast cancer. Now on triple negative breast cancer patients. So who are those? Those are the people whose cancer doesn't have estrogen or progesterone or HER2. So-called triple negative. The traditional therapy for these patients is chemotherapy. Or, like I mentioned before, there's this medication that is just for the BRCA mutation that they could be using as a pill medication. And more recently, immunotherapy has been approved for these patients. So what is immunotherapy? I wanted to just mention that a little bit because you hear so much about it on the news and on the boards. So let's say this is a cancer cell, and this is your immune cell, so-called T cell, which is a type of immune cells. Normally, if there's a tumor cells have all these proteins, so-called antigens, that are not normal. And if an immune cell recognizes that, then it can basically direct itself to try to kill those cancer cells. But a lot of cancer cells have figured out a way against it. They have a different thing on their cell surface, so-called PD-L1 or programmed cell death ligand, that binds to this other thing on the immune cell, that this actually is like a brake, inhibits this and completely turns off the C cell. So it doesn't matter that it sees these other proteins that don't belong and should kill this cancer cell. This is like an off button that overrides everything else. So what we have now figured out is drugs that either cover this or cover that, here, cover this or cover that, so this interaction can't happen. If this interaction can't happen, then an off switch cannot be pressed, then the immune system can actually go ahead with its recognition of the tumor cell as something foreign, something that does not belong, and try to kill it. So this is the concept. Now, it's a little bit more complicated than that, and it doesn't always work. But at least in triple negative breast cancers, it has been tested now a few times. And basically, they tested cancer cells that have this PD-L1. Not all breast cancer cells do that. Some of them use other methods of evading the immune system. And they basically half the group got just chemo, this particular chemo called nab-paclitaxel or Abraxane. And then the other half got the chemo plus this drug that is an immunotherapy drug. And they saw that they actually had improved survival and very little side effect actually compared to chemo alone. Now, this is right now approved only for patients who have this PD-L1 positivity, and it still has to be combined with chemo, but is another thing in your arsenal at treating patients with triple negative breast cancer that you didn't have before just a few years ago. So I'm going to finish up now, so we'll leave plenty of time for question and answers. So in conclusion, breast cancer can be curable when diagnosed early. And early, thankfully, is anything in the breast/lymph node that counts as early. Treatment obviously involves surgery, but also frequently a lot of other things. Chemotherapy, hormonal therapy, and radiation therapy. So it is critical that when someone gets diagnosed with breast cancer, they don't only see a surgeon. They need to see a medical oncologist at the very least, at the very same time, so that there can be a discussion between medical oncology and the surgeon And the medical oncologist can advise a surgeon if for that particular patient, for that particular cancer type, maybe chemo would be better beforehand. And always, always ask for clinical trials because that is your opportunity to get something in addition to what is already on the market. For example, that cat salad drug, I was involved in the clinical trials that were done before it got approved. And it was marvelous to be able to try that and give patients something more than they would have otherwise. And many other ones, the tucatinib and HER2. I was involved in all of those trials as well, and all those drugs are right now approved. And those patients who got on the trials got to use them much, much earlier than they would have otherwise. So always, always ask about any clinical trials. So this is just the phone number to Margie Petersen Breast Center. If you or anyone you know needs to be seen by medical oncology as well as surgery. And I will open it up for questions now. So let's see. So there's one question that this person is asking. They have stage 4 breast cancer that has gone to the bone, and they're doing very well on Faslodex for about 4 years. Is there anything else that can help me? So that's an excellent question. So Faslodex, and let's see, and I'm gonna stop actually sharing so that you guys can just see me. So Faslodex is an anti-hormonal medication, and it's similar to the aromatase inhibitor. So it's a very good drug for a person who has a hormone-positive breast cancer, such as this person. And it's basically something that would be their backbone. Now, one caveat. Doesn't look like the person who's asking this question is on a CDK4/6 inhibitor. CDK4/6 inhibitors have been, having more and more research behind them for the past, few years. At the time that you were started on Faslodex 4 years ago, we didn't have any data that you should do these earlier. The thought process was you can start them either at the beginning or whenever the person didn't respond to the anti-hormonal therapy, you can add that. But since that time, about 2 years ago now, a little less than 2 years ago, we have had now trials coming out that adding a CDK4/6 inhibitor before you develop a resistance to Faslodex actually improves survival. So that would be a discussion I would have with your oncologist. Is it worthwhile to add a CDK4/6 inhibitor, which is a pill, to my regimen to improve my survival? Granted, you haven't been on those before. I didn't see it in the question. They would have additional side effects, but they also improve survival. So I would recommend that you do discuss that with your oncologist. So, all right, let's see. Another question. How does the drug letrozole inhibit estrogen? So letrozole, anastrozole, and exemestane are the 3 aromatase inhibitor drugs that are right now on the market. How do they work? So aromatase is the name of the enzyme that makes estrogen in a postmenopausal woman. So tissues such as fat tissue, muscle tissue, they can make estrogen even when you're gone through menopause and the ovaries don't make any estrogen. And that estrogen production is made by this protein called aromatase. So letrozole, anastrozole, and exemestane inhibit that enzyme, so can no longer make estrogen. So they inhibit the making of estrogen. That's how they work. But the reason we can't use them in a premenopausal woman is that aromatase is not the enzyme that makes estrogen from the ovaries. So if you use them when the ovaries are still making estrogen, you are not completely inhibiting estrogen production. So you can only use it if a person is postmenopausal or you add an injection, suppress the ovaries, and then you can use letrozole. Hope that answers your question. Next person, can aromatics be exchanged for something else? Yes, you can. So as I was just saying, aromatics, which is another name for anastrozole, is one drug, and then exemestane and letrozole are also in the same class. So let's say somebody had a lot of side effects from anastrozole, it's definitely worthwhile to try one of the other two. And it's possible that one, even though anastrozole is not supposed to be any worse than the other ones, any drug can be different in a given person. So it's definitely worthwhile to try to change it around if need be. Okay, let's see. Okay, so this is a question from someone who has lobular cancer, and they have metastatic lobular cancer. And they're saying that they are right now an aromatase inhibitor and a CDK4/6 inhibitor, which is appropriate. And they're asking, how can they be followed? Because lobular cancers can be sometimes hard to see on a PET-CT scan. And they're interested in this new scan that we do have actually at St. John's. So lobular cancers, they not only are hard to see on mammogram, a lot of times they're also easy to miss on a PET scan, a traditional PET scan, because how does a traditional PET scan work? You basically are trying to see cancers that take up the sugar more than your blood does. And lobular cancers and some other some ductal cancers are so slow growing that they don't take up the sugar that much to be able to see the difference and to be able to really follow them on a PET scan. So this new scanner is called FES scan or Siriana scan, and it targets the estrogen receptor itself and not cancer cells that only take up sugar. And we have started doing it at St. John's. I don't recommend it yet for just ongoing maintenance because it's new and still a little bit considered experimental, but it would, for the right person, I have been doing it, and it can be a good adjunct. We actually are starting a trial here in a few months, trying to do that and seeing, how does it change management so that in a context of a trial, we can formally evaluate that and seeing, do more and more patients benefit from this. So outside of a trial, in your scenario, you have metastatic lobular cancer, I wouldn't use a PET. I agree. I don't think a PET is going to be very helpful. I would do CT plus bone scan. That would be much more helpful until we have a better scan. Okay, let's see. I have estrogen positive lobular, and I had it 2 years ago, had lumpectomy, radiation, and as well as an anastrozole or some aromatase inhibitor. Fortunately, same type is back. What do I do? Do I do a mastectomy? Do I take out one breast versus two breasts? I'm sorry that only 2 years afterwards you had your cancer come back. This is something that I have to actually review the data and review what has happened to you, because this is not typical. It's not typical that in just 2 years, even though you've been taking your medication, it has come back. So something more is needed. So this may be better if you want to reach out, if you want to see me. I would need to review and see why it happened, because I completely agree. You need something more. You may need chemo this time. You may need mastectomy. You may need genetic testing. We really need to have to figure out what happened, because you should know this is not typical. So please reach out if I can help. And I see one other question, and I'm not sure if there are any more questions after that, but I'll see. Let's see. Have there been any advances in treatment for inflammatory breast cancer? So I didn't really talk about inflammatory breast cancer per se. Sorry, I didn't have time to cover everything. But inflammatory breast cancer is cancer that you can see clearly is involving the skin, and the skin is red. The skin has this like as if it's like a orange peel, this like that specific texture that is like going into the breast, that kind of appearance, and they're typically much more aggressive as a result. Now, in terms of its treatment, the only difference between that and the rest of breast cancers is that usually you can't do like lumpectomy or preserve the skin. But the other thing that we found more and more about it is that it's usually better to do chemotherapy for these patients and do it before surgery, because this cancer is aggressive and you want to get to it as soon as possible. And then what type of chemotherapy you do, then it's the same as all other cancers. You really need to look at what it drives its growth from. Is it hormone positive? Is it HER2 positive? Is it triple negative, which is much more common in inflammatory breast cancers? And choose your chemotherapy accordingly. So it's more in terms of what you do first and how much you do, rather than exactly the type, because that is more dependent still on the type of breast cancer. Okay, let's see. I'm taking tamoxifen, and this person had 2 breast cancers, HER2 positive and not. So she had a complete response after mastectomy to the chemotherapy against HER2, but she's having a hard time with tamoxifen. Is there any other way to control the hormone levels? Depends on what is the issue, because some things, there are over-the-counter medications, there are medications that can help. Depends on what it is that you're having a hard time with in terms of tamoxifen. But another option would be the ovarian suppression with an injection, plus the aromatase inhibitors. So that would be the other option. So I would talk to your doctor about both, meaning what are the issues you're having with tamoxifen, what can be done about them, as well as these aromatase inhibitors and ovarian suppression, and see what makes sense for you. Are there things we can do to just keep you on tamoxifen, or should we just switch gears and go to that other route? And some people tolerate them better. It really depends on the person. Some people tolerate tamoxifen better. Some people tolerate the injection and aromatase inhibitors better. So it really depends. Can you comment on new molecular imaging techniques? So basically, molecular imaging is something that is right now being developed and is on a research basis. And we're doing that at St. John's as well, trying to basically do genetic testing as well as imaging at the same time. And that is in its infancy, and we are not there yet in terms of being able to use it for everybody, and is extremely expensive as well. So that is something very exciting that is hopefully going to come in the future, meaning like when they see the cancer, the picture, they can also see what type it is and what it drives its growth from, and really be able to figure out treatment that way. And so that is to come, hopefully, but we're not there yet. Let's see. I don't see any other questions.
Let's give it one more minute just in case we have one more question coming in. But in the meantime, just a reminder that this is being recorded. It will be up on our website in just a couple of weeks, and I'll be putting our website into the chat feature now if you are new to CSCLA. Don't see any more questions coming in.
Great. Glad I got to everybody. Well, thank you for coming.
Thank you so much for
having it helpful. Oh, there's one person.
Oh, one more.
Do you have palliative care supportive services at St. John's, and how do you see growing the Margie Petersen Breast Center? So we do. We have very good, actually, palliative care supported care at St. John's. Um, Even when I was not at St. John's, I was using those services. So we have a dedicated psychosocial service team that has a psychiatrist dedicated to cancer patients, as well as that team has social workers and a nurse practitioner that all work together. Typically, when I have a person who needs that, I can get them in to see the patient same day, to be able to see the patient, reach out to them, and plug them into St. John's and to the supportive care services. So they're fantastic. They're fantastic, and like I said, I was using them before I joined St. John's. And how do you see growing Margie Petersen? So I've been very excited to join Margie Petersen, and what I am hoping to do is develop our clinical trials program, as well as our medical oncology breast program. So I have multiple clinical trials right now that are in the pipeline, including the one I mentioned about that new imaging technique. And so that's a major thing, as well as just focus on what St. John's does best, which is personalized treatment and taking care of each patient individually, and with a strong sense of the community, which I really like about St. John's and all the doctors that are involved. So it's so yeah, very very pleased to be part of it and hoping to grow it, in terms of the clinical trials, as well as just building on what it already does really well at. And one other person is like, okay, this is a different question. Do bone mets ever spread to the liver or other organs? Yes, they do. So when breast cancer spreads, it can go anywhere, and sometimes it starts in the bone, but the progression is it does go other places, which is critical that these patients be followed carefully with regular scans, as well as be on the right medications, so to prolong that time before it spreads somewhere else as long as possible, and hope that better drugs come along as this person is getting treated.
Okay, it looks like that was our last question. Thank you so much, Dr. Peddi, for being here again. Thank you to all of you for joining us today. We are happy to be holding this in honor of Breast Cancer Awareness Month. And with that in mind, please note that we also have 2 breast cancer support groups at Cancer Support Community Los Angeles if you're interested in joining us. We have one for metastatic breast cancer and a general breast cancer support group. So if you're interested, I also just put that into the chat. You can email us at info@cancersupportla.org if you're interested in learning more. But thank you so much for your time today, Dr. Peddi.
Thank you so much for having me. Thank you so much for all that you guys do. Cancer support community has been around for a long time, and it's absolutely critical because a lot of these services are not covered elsewhere. And it's a very good community for cancer patients of any stage.
Well, thank you. We are so grateful to have your partnership, Dr.
Thank you.
Thank you. Take care.